So hello, Ali Cracknell. Welcome to the Essential Implementation Podcast. Perhaps we can start with you just telling us a little bit about yourself.
Hi there, my name's Ali Cracknell. I'm a consultant in medicine for older people at Leeds Teaching Hospitals, but I'm also Associate Medical Director for Quality Improvement here and work with the Improvement Academy on implementing healthcare improvements across the region. And I guess over the last 10 years, I would say I've been learning and never-ending learning about the art of improvement and implementation. So how you may know the science, but how do you do that in real practice?
Great. And something that you've are quite well known for is the implementation of safety huddles. Is that something you could tell us a bit about?
Yeah. Okay. So safety huddles, we always say, like, we've never invented a safety huddle. I mean, I always say the definition of a huddle is simply a focused gathering of people. But what we've tried to really understand is what makes the most successful huddle, what brings the biggest impact in terms of staff teamwork, and what might bring the biggest impact in terms of reducing harms to those patients you're looking after and adjusting to the conditions of the day and the shift that are ever changing. So we wanted to try and improve things even further in some of our teams in Leeds, and we decided we'd try and look at the concept of a safety huddle. Could a huddle help us reduce harm in our patients? And that, I guess, again, has been a never-ending journey of learning.
Yes. How did it start? How did it evolve? And how did you get to where you've got with safety huddles?
Yeah. Okay. The first thing is to start very small. With sort of one team, like an innovative team that is up for trying to try something to make a difference. And obviously that's much easier if it's a team you are involved with or got direct influence over. So we started on one or two teams that I either worked directly with or worked closely with. They were passionate about trying to reduce, the thing they were about was falls, but they actually believed they were doing everything they could possibly do, and falls were still inevitable and happening. And that's why we started to think, well, what else could we do differently other than sort of the routine things we do at individual patient level to try and prevent them falling? And some of that was about looking at the bigger picture of how we use the staff, how we use our individual skills and our individual knowledge of the patient to harness that as a team. So we decided that the team were happy for giving it a go. So firstly, we reassured them from the evidence of safety huddles in healthcare, which was quite limited at the time, that there's no evidence this would do any harm to their patients. Okay, so let's give it a go, 5 to 10 minutes one day. Let's see if we all get together and have a chat about what can we do to reduce falls today. That's basically what we did with 1 to 2 teams. We had a 5-minute timeout, generally fairly early on in the shift, to say who we worried about falling today and what can we do as a team to try and reduce them falling. Has anyone fallen in the last 1 to 2 days? And if so, why? What's the learning? So we start to share that learning and knowledge about why our patients are falling real time. What is it about those individuals or the circumstances? And we start to see that we can go shifts without people falling. And we don't define who we really worried about. If somebody's really worried about somebody falling, we discuss them. Okay, so what can we do as a team today? Do we need to review where the patient's positioned on the ward? Do we need to look at their walking aid? Do we need to look at their medication, their footwear, etc., etc.? What do we need to do to reduce this risk of the patients falling? And what we found is it sort of enhanced the whole team's situational awareness. So everybody would leave that huddle sort of knowing the people that were highest risk of falling at that moment in time. So it was in their head. So if I went into a bay of patients as a doctor and I could see, you know, in my peripheral vision that so-and-so was trying to get up, it's in my mind, oh, I've got to help that person. They're actually high risk of falling. Basically, we went through this not really knowing exactly what we were doing, but just testing it out. But we started to look at the data as well about whether our falls were changing. And over time, we got a bit more slick about how the huddle sort of developed and evolved over time. And a couple of other staff used to work on different wards, so they'd come to our huddle and think, it seemed quite a useful thing,
Yeah.
but without any evidence of impact, they took it to their own ward to just start testing it out in their world as well. And then what we found over a period about 4 to 6 months, we started to see big impacts in our falls with statistically significant reductions. And actually all we were doing is getting people together for 5 to 10 minutes to discuss the risk at that moment in time, and what we're going to do about it as a team today. So as it spread, it maybe spread to 3 to 4 other areas, and probably learning from those 3 to 4 who sort of took it away with them without us being directly involved or knowing what they were doing. That's where you learn quite a lot. They've taken an intervention that isn't quite proven yet and started to already adapt it into their own world. And we started looking at their data and seeing that they were making a difference as well. Then we started to study to try and understand what seemed to be the key ingredients. Every huddle was starting to look a little bit different in these 4 units, but what is it? What were the key ingredients, if you like, that made it successful? And we maybe came up with 4 to 5 things at that moment in time that seemed to make a difference. I'll tell you a few things. One was there was a bit of data about when was your last fall, what's the learning from it? And equally, if you'd gone a long stretch, there was also celebration. Wow, we can go 10 days without a fall. It starts to change mindsets that you can go 20 days, for example, or 30 days. So data is important. Secondly, that it's a whole multidisciplinary team are invited. So it's not just doctors and nurses, therapists, pharmacists, care support workers, non-clinical staff, ward clerks, housekeepers, etc. Third is the focus on the huddle should be owned by the team. So we started in a lot of elderly care wards where actually falls is one of our biggest concerns and risks. So that's what the team wanted to focus on anyway. But actually it should be what's important to them. So if it's not falls, it's something else, so they can adapt the focus of their huddle to what's important for their patients at that moment in time. It's got to have leadership to the huddle. Now, initially, we did think that might have to be a senior person, like the nurse in charge or the consultant. But we soon learnt from those other wards that it's got to be the most appropriate person for that ward. It doesn't have to be the most senior. It's got to be somebody who's credible, enthusiastic, passionate, and respected by the team, basically. And that the huddle is sort of celebratory. You know, it's done in a non-hierarchical manner, but you can celebrate your achievements as well as learning from when things haven't gone perfectly. So those were sort of the early ideas we got about what are the ingredients, if you like, to a successful huddle. And we started to learn from those early adopters that it could be done different. It didn't have to look the same on every ward to get impact.
I have to say I'm extremely impressed. So you've got a lot of things in there which we know from implementation science will increase success, like the leadership. You used to talk about the key ingredients, but the bits around it that you can adapt. So it's adaptable, making it their own in a way. Also, not just having whoever's highest in the hierarchy, lead it, but whoever's, so the personal characteristics. How did you know to do this? Was this just came from instincts, or?
So it came from the learning, because it sort of naturally evolved like that over those early wards. And I guess at that time we were not planning to spread it anywhere. But as it spread a little bit into these enthusiastic areas, that's when we started to challenge ourselves and think, wow, you know, it's making a difference to these units within elderly care, but actually in a large hospital, we're not going to see a fundamental impact on patient falls or harm unless we look at how you can do it at scale.
I see.
So I guess we didn't plan to do it like this. We naturally got some spread because those teams that had observed it were, if you like, the enthusiasts who felt it was a good thing and could possibly, without the evidence, start to see it was a good thing for the staff and a good thing for their patients. That then came the challenge, right? If you want to make a big difference to patient safety, how the devil are you going to do this on 90 different wards or in different hospitals?
Yes.
So that, I guess, is when the real challenge in learning came.
Yes. Because I mean, you know, not everybody's going to be as enthusiastic. They're going to have different experience, you know, different things that they're focused on and different views of the world and all that sort of stuff. Everybody's. So how did you face that and how did it go?
So I guess to try and plan how to do it at scale, that's when we had to reflect a bit about the early spread, if you like. So you sort of say, well, how did you know? Did you deliberately do these things? Well, no, we deliberately studied them after it had evolved to see how the devil we're going to do this at scale. Because we've got the evidence of impact, not just on harms, but also on that there was evidence it improved teamwork and safety culture.
Right.
That again can only be a good thing.
Yes.
But again, if it's only in a few wards in one hospital, you know, you've got to challenge yourself about how can it be done and make bigger impact. So that's when we started to work further with the Improvement Academy and started to plan, could we do this at scale? Could we learn how to do this in different hospitals and in every ward, in every hospital?
Yeah.
So now that obviously takes resource planning, time. So that's when we got a Health Foundation grant.
Right.
To work out, can it be scaled up across 5 hospitals in 3 different organisations in Yorkshire? Okay. And I guess the great thing about a grant like that is the Health Foundation, who are passionate about improvement, would recognise, you know, it's okay for things not to work. You've just got to learn why things don't work. So in some ways it was a great opportunity, a bit of pressure, but the most important thing is to get the learning out of it. So I think we had 2 years of work to scale up on, I think it was about 100 odd wards across these 5 hospitals. We tried to stick to our principles of what we'd learned in the spread. You know, you need to start with the enthusiastic teams. You need to get them to believe it can work for them, and start to get them telling their stories and sharing their data with local teams to them. So they become champions of it. So let's say in a hospital like Leeds, where we'd already started the work, it was quite an easy sell, if you like, because they'd already heard of other teams seeing improvements in their falls. And we could ask some of the sisters or the healthcares or the pharmacists to come and engage those teams. You know, why wouldn't you want to do this? You know, we didn't think it would work, but actually it takes 5 to 10 minutes a day. It's reduced our falls and it's improved teamwork. So why wouldn't you give this a go? And we're here to help you. And we sort of set up, each unit had a huddles coach to sort of just observe, support them, nudge them, take them through the key principles, but not tell them how to do it, just to support them to test it using like improvement PDSA cycles. Test it in your environment. This is what the principles we think would work, but we need to learn with you how it works on a specialist surgical ward, for example. And that's when we started to learn that it could work with reducing avoidable deterioration of patients. It can work for reducing pressure ulcers, because not every team chose to focus on falls.
Yes.
And then we also were doing it in 2 other organisations in Yorkshire. So again, that was probably harder to begin with, because you're going with something, although there's local evidence, they would say, well, that worked in Leeds, you know,
Yeah.
can it work in Barnsley? Can it work in Scarborough? I don't know, but you know, if you're up for trying it, why wouldn't you want it to give it a go? Why wouldn't you want to be the first team in Barnsley to have a 50% reduction in your fall? So you need sort of some local knowledge about which teams are going to be the enthusiastic ones to give it a go, and you need some organisational sort of senior level leadership to support you. But I guess what we learned is we didn't want anyone to sort of mandate teams had to do it, or we didn't want them to put pressure that it had to be done on every ward. We wanted to see if it could be done, and if so, how is it done? And it's okay if you don't want to do it. It's okay if it didn't work, for example. But we started to get those local success stories that then helped it spread.
Yes.
And then other things that help. So, for example, in Leeds, we hadn't necessarily shown that it worked on specialist areas, say labour ward. But actually, Barnsley Labour Ward were really keen to give it a go, and they got a really good huddle going around reducing third-degree tears, for example, and improving teamwork and communication. So then that changed my mindset that actually huddles could work on labour ward. You've just got to work through how it's adapted in their world, and then Leeds can learn from Barnsley Labour Ward, etc. So you sort of start to connect teams, and we don't necessarily come with the solutions, but we can help connect people who've had similar challenges or maybe similar units. So in the end, we learned that huddles could be implemented in about 90% of wards without mandating it or forcing it. And virtually all of that is sustained sort of 3-4 years after the grant has finished.
Right.
Because I think it's because people believe in the value of the huddle. They can see the sort of, it's one hearts and minds. They can see it works for them and their patients. And they own it, and you know, nobody's policing it or telling them they must do it every day.
There's so many gems in what you said.
Yeah.
I mean, the fact you were collecting data early on is, I mean, hats off, because, you know, I'm not sure how many teams would have done that, but you did. So you had the proof over time.
I think that's really important. Yeah.
And also letting people not mandating it.
Yeah. And letting them sort of adapt it into their world, because we learned a lot from that ourselves. That it can't be done just one way, because that worked that way in the area I work, for example.
Yeah.
You can't control it that much, you know. If you want people to do it, you've got to let go a bit.
I see.
Yeah.
And do you think there are perhaps different groups of people within the NHS with different job roles and different long-term goals? And do you think there are some groups that are more likely to be able to accept that, you know, we're going to not control this so much, we're not going to mandate this, we're going to let people try it and see? Do you think some groups find that harder to, I guess I'm getting at, say, executives or middle managers?
Yeah, I mean, I think it is hard, because obviously if you've got something that works, everybody wants it working on their unit, don't they? Why wouldn't you?
Yeah.
But if you try and force and push it without letting the learning happen, then it's more likely to fail or not happen when, you know, someone isn't sort of demanding it to happen, if you see what I mean. So I guess, I mean, that early learning stage, we had our chief medical officer was hugely supportive of it. But what she would actually say her learning would be is she deliberately protected it from performance management. So it wasn't going to boards. She wasn't reporting, 50% of the wards are doing huddles, 50% aren't at this moment in time. She was letting it flourish bottom up with the learning and giving it a bit of time to sort of develop, and then obviously helping celebrate the wins and the successes with each team.
Yeah, so you got the reflective aspect there as well.
Yeah. But then having the grant of trying to learn how to do it at scale meant we had the pressure to try and get to every area, which I think you sort of need that as well, because otherwise you could just stop going or trying on the wards you think might be more challenging, or you don't know how to do it because it's a specialist unit. Whereas there was that bit of sort of robustness that we had to try and do it everywhere to keep do you see what I mean?
Absolutely.
Yeah,
yes.
I couldn't just walk away from any unit. I had to see if we could do it.
Yes. So a little bit of pressures in that way was quite helpful.
Yeah.
I mean, it really does strike me as a great example of perhaps what characteristics are needed for an intervention in this kind of setting to be a success and how to go about it.
Yeah, I think another thing is we got a lot of belief that it was a good thing to be doing. People believed in it, and obviously because I believed in it, and then I started to see the evidence. We were getting more and more passion to try and take it further.
I mean, this is very interesting because if you think about the traditional way things usually come into play within healthcare settings, is that you have a research team that's quite separate to the environment, to the setting, who will spend it could be a number of years developing an intervention, and then they will do some trials and show that it's effective, and so they've got the randomized controlled trials, and then publish it, and then it's basically given to people like you to implement. And I guess so the way you've done things is quite different, because you've started out in an organic way, a kind of open way, and you've developed something, and you've collected some data, you've shown it's worked, and then other people have seen this, and then it's kind of spread, and then they've taken it on. You then got a grant to help, and then the Improvement Academy. So this whole thing's organic. That's quite different to it being developed and then sort of handed, isn't it?
I agree. I mean, people said to me at the beginning, don't you need a randomized controlled trial of whether huddles work or not? And I guess I was just thinking, well, you can't really control it. You can't control all the biases that might be out there. You can't. We'd sort of learned that there wasn't one way to do it. And if we said you need to do your huddle like this because this is the evidence for it, then you're sort of mandating the way to do it. And we sort of knew that was more likely to fail in the first place. So we ended up with sort of something that's a bit out of any control. But if you can try and keep the sort of concept of a huddle and the coaching and the support under some sort of control.
So although we've come out of, well, we're still in, but we've had this golden age of the randomized controlled trial, and everything has become, most things are evidence-based. Do you think there's maybe a sweet spot actually where sometimes it's maybe better overall to use perhaps lower quality evidence to roll things out more quickly and see if they work that way, rather than waiting years to prove?
Yeah, I guess you're learning about the implementation side as well, aren't you, and the adaptation, which you don't get in a randomized control trial usually.
No.
But then you have to convince people of the evidence. So it's okay for something like a huddle where we did get good evidence they could change things at unit level quite quickly. So we did have evidence to get people on board, but I guess not every intervention that you're trying to implement has genuine evidence at unit level. It's going to make a significant difference to people or patients.
Yeah, I mean,
it's a challenge.
It is a challenge, isn't it? It's almost like in this case you're able to do a hybrid, really, because simultaneously you were researching the implementation, whether it was explicit or not. That was what you were learning, as well as collecting evidence.
Yeah.
those both at the same time rather than just one, or okay,
I mean,
that's yeah.
There's other things I've been involved with since at trying to sort of roll out or spread. But if we haven't, and I've learned from those not working, you know, if you haven't been able to get the sort of buy-in from the staff, they can't see what's in it for them, and you can't adapt it into their world. If you're too rigid, then people just don't do it when they've got enough other things to be doing.
Yes.
And yeah, you may need to be, you know, passionate and believe in it and gather evidence and have senior support and evidence that the tool works, but you also need to work with teams to allow it to work for them.
So I will say, Dr. Ali Cracknell, thank you for coming on Essential Implementation. It's been an absolute delight talking to you. We hope to see you again soon.
Thank you very much. Take care.
You too.